Wait for a minute, sir. Let 20 students come.
Yeah,
Then we can start.
definitely. Let's wait for 2 minutes. अभी आपको करता हूँ वेबिनार।
Sir, we are live.
All right. Can we start, sir?
Yeah, please.
I think, yeah.
Right. Okay. So, good evening, beloved course directors, as well as the experts, examiners, and the dear students. Thank you very much for joining us for our 23rd Master Bedside Clinics in Nephrology. It has been an honor that as per the schedule of this entire financial year, so we will be completing our 23rd session here. So we are extremely grateful for the students who have been constantly placing and joining us on time. We really appreciate your time, and I'm sure the learning is helping you to give you better in terms of gaining an edge in nephrology. So before we further go on to our program, I request our course directors. I welcome Dr. P.P. Varmaji as well as Dr. Vijay Kher for today's session. I request Dr. P.P. Varmaji to give a intro of today's experts and the examiners and the students and take the program from here. Over to you, sir.
Thank you very much. As Mr. Raja, as you mentioned, we are in the 23rd Master Bedside Clinics in Nephrology. Today, we are discussing a very important topic, that is chronic allograft injury. And we have got two very good, very senior academicians and revered teachers, Professor Sandeep Mahajan, who is Professor of Nephrology at All India Institute of Medical Sciences, and Professor Ratan, who is heading the Department of Nephrology at Kher Hospital, Hyderabad. And we've got an expert, a friend of mine, very dear friend, Dr. Professor D.S. Ray, who is HOD Department of Nephrology at R&T Hospital, Kolkata. He has got passion for transplantation, and I'm sure probably he is doing the maximum transplantation, renal transplantation in Indian scenario. And welcome to all the examiners and experts. And we have got two students who are presenting two different cases. Dr. Aman, he is a student of Professor Ratan from Hyderabad, Apollo Hospital, and Dr. Bharadwaj, he is a student of Professor D.S. Ray. I request Professor Vijay Kher to introduce the topic, and only then after that we can proceed with the proceedings of today.
Thank you, General Varma. I think welcome again to this episode of Master Bedside Clinics. And I think chronic allograft injury, as most of you would know, is a slow deterioration in kidney function and is commonly found in patients with long-term in patients of kidney transplantation. And there are multiple reasons for this. And as we will see, at least two patients who will be presented today will unfold at least some of the causes of chronic allograft dysfunction and how does one evaluate and go about finding out the cause for this. And General Varma has already talked about that this is two experts that we have who are going to be the examiners, and then Dr. D.S. Ray is going to sort of provide some his own personal opinion also about it. And our role predominantly is to sort of be observant and just learn as much from these people, as much from the students and all of you. So without any further ado, I will request Dr. Aman to present the first patient, and I will request Dr. Sandeep Mahajan to sort of maybe ask most of the questions. Dr. Jha would probably not. Dr. Aman is a student at the Apollo Hospital in Hyderabad, not Dr. Jha's student directly. He's Dr. Jha's son, And
Sure.
so we will ask Sandeep to ask questions. Yes, Aman, go ahead.
Good evening to everyone. Today I'm going to present one of the interesting cases that we are following up in our center. So I would start with the current presentation. Mrs. M is a 43-year-old doctor. She underwent a live renal transplant 14 years ago. She presented to our OPD 3 days back with history of foaming of urine, worsening of her blood pressure, and decline in renal function with a rise of creatinine to 2.8 mg per day. Getting my background history, at the age of 23, she was found to have hypertension on evaluation and a creatinine of 2.7 mg per dl on evaluation for headache. Her biopsy done showed a chronic IgA nephropathy. The urine reports are not available with her at that time. She was managed with diet, ARP, statins, vitamin D supplementation. She denies any history of hematuria or foaming in her urine. She was under a regular follow-up for the next 4 years. She reached end-stage renal disease, that is a GFR less than 15, at the age of 27 and opted for a preemptive transplant. She underwent a live renal transplant.
Dr. Aman, she remembers her biopsy, but she has no urinary findings, so she can't recollect her urinary findings.
She doesn't remember her urinary findings, sir. I
But
asked
she
her many.
says the biopsy she says was IgA nephropathy.
Nephropathy, sir. Yes, sir.
Okay.
Yes, sir.
Okay, carry on.
Yes. She underwent a live renal transplant with aunt as donor, received induction with interleukin-2 receptor blocker. It was ABO compatible and an HLA mismatch. The transplant procedure was uncomplicated and the graft worked immediately. She was discharged with a creatinine of 1 mg per dl on triple immunosuppressants, that is steroids, MMF, and tacrolimus. She did not require any antihypertensives after transplantation. She did not require any blood transfusions during surgery nor before.
Okay, and what do you mean by saying HLA mismatch?
Sir, she basically HLA mismatch in the sense she is unrelated to the recipient, sir. She is the wife of one of her uncles, and she donated the kidney. There was not a much match. If she doesn't remember the match exactly, so as they are unrelated. So
there is no need to comment upon the HLA mismatch unless you are looking at, say, something in which you have a preformed donor-specific antibodies or something of that sort. There would be only a very small percentage of 1 or 2% who would have 100% HLA match, right? So rest all technically would be HLA mismatches. So by HLA incompatible, the term HLA incompatible is reserved for those patients who would have a donor-specific antibodies to them, right? So if the patient remembers whether it was a haplo match or it was not a haplo match, it's fine. Otherwise, you can just say live unrelated renal transplant. With a presumption, obviously, there won't be HLA matching.
Pregnancy post-transplantation. 5 years post-transplant, at the age of 32, she got pregnant without planning. MMF was replaced by azathioprine. In the 7th month of gestation, she had a premature rupture of membrane requiring emergency C-section. The baby was underweight, requiring neonatal ICU care. She remembers her creatinine being around 1 mg% then, and she denies any history of pregnancy-induced hypertension. Post-pregnancy, next 7 years, she enjoyed good health and her creatinine stayed between 0.9 to 1.1 mg per dl and her urine routine reports were normal. At the age of 39, on evaluation for abnormal uterine bleeding, she was diagnosed to have hypertension with a BP of 150/90. It was controlled with one antihypertensive, that is cilnidipine. She underwent a hysterectomy for fibroids. In June 2022, at the age of 42, she contracted a COVID-19 infection, requiring only home isolation. Post-recovery, her creatinine rose to 1.4 mg per dl with a baseline of 1.1. She received 3 Covishield vaccines, and the last vaccine was 6 months before the incident of COVID. There was no change in immunosuppression done during her COVID infection. Recent problems, that is in December, 6 months post-COVID, she developed symptoms of headache and blurring of vision with her BP rising to 220/120. She required 4 antihypertensives for her optimal control. She admits to having foaming in her urine. Her serum creatinine rose to 1.8 per DL. A urine protein creatinine ratio was done that showed a ratio of 3.2. A transplant Doppler was done and it's normal. Recently, that is like 14 years post-transplant now, her blood pressure has been brought under control with 4 drugs. She's on triple immunosuppression, but her creatinine has risen up to 2.8. That was 1.8 2 months ago. Now she underwent a renal biopsy.
Okay.
Yes, sir.
Okay, Dr. Aman, if we just go by the history, what do you think we are dealing with? Can you just, in a nutshell, summarize and give us a provisional diagnosis?
Yeah, yes, sir. My provisional diagnosis would be there is a chronic allograft dysfunction, and based on a history of IgA nephropathy, I would like to put recurrence of IgA as one of my differentials. And the other thing I would like to think of is a chronic antibody-mediated rejection. But I would also like to rule out other causes, that is of drugs, CNI toxicity, or any underlying infections, obstructions.
Can I intervene?
Sir.
Dr. Aman, if the blood pressure has got significantly up, requiring suddenly 4 drugs, and there is some amount of proteinuria, would you like to exclude renal artery stenosis, graft artery stenosis also?
Yes, sir. I would like to rule out renal artery stenosis.
Would you like to do a Doppler or something of that sort?
Yes, sir. I would like to do a renal
He has
artery
mentioned that the
rule
Doppler
out.
is normal. He does
Yes,
mention in the history that the Doppler has been normal.
Yes,
Okay, okay.
He does mention, but it's a very important differential. So that's what I was coming to. If you have to accommodate in your differential diagnosis severe hypertension, which is of recent onset, what other important differentials which you have to keep? So recurrence of IgA nephropathy would not lead on to such a severe hypertension all of a sudden.
yes, sir. Chronic antibody-mediated rejection could also cause uncontrolled hypertension, sir. Worsening of hypertension and graft function. It could be a presentation.
Okay, so that could be in any. It could be even in a recurrence of a glomerular disease. But she is a medical practitioner. She obviously has been taking good care of herself. And then suddenly suddenly in a week's time, she'll develop headache, vomiting, and a severe blood pressure of 220 by 120. Right?
Yes, sir.
This is what you mentioned in the history.
Yes, sir. Yes, sir.
And from one
She had a
antihypertensive.
COVID infection 6 months before she had this incident, sir.
So can you keep another differential in your diagnosis then? We might or might not be correct, but as a physician, if a stable post-transplant patient within 6 months of a COVID illness comes with increasing requirement of antihypertensive drugs, severe hypertension, does not have a renal artery stenosis on a Doppler.
So you think of other causes of hypertension, Dr. Aman?
Then any TMA, sir. There could be any TMA secondary to COVID.
Very good. So you could be dealing with a TMA which has got precipitated by the COVID illness. That could be one possibility of such a severe hypertension, graft dysfunction.
Yes, sir.
Right. Though proteinuria as such won't classically occur. So the frothiness of urine would be one thing which is a bit difficult to explain by this case scenario, but it has to be part and parcel of one of the important differentials.
Yes.
The historical correlation with the COVID illness, severe malignant hypertension. You can have hypertension, severe hypertension itself can lead on to proteinuria. Secondary FSGS, as we are so fond of calling it. So it could be that possibility. So that should have been there in the differential diagnosis. It's still an important differential.
Yes.
Any drug-induced TMA which can happen?
CNI associated TMA is also a possibility. CNI toxicity can also lead on to a TMA like nature, sir.
Perfect. So it can be unrelated to the duration of the transplant. So it can occur early in the transplant. It can even occur later in the transplant. So even that can't be completely excluded. Right?
Yes,
So
yes,
accommodating TMA as a differential would have been an important aspect in your clinical case.
yes, sir.
So we have multiple discussion points in this particular case. We have a preemptive transplant, right?
Yes.
What do you understand by preemptive transplant?
Before the development of any uremic symptoms, when the GFR begins to fall till 15, sir, they undergo a transplant. A preemptive transplant is the transplant before the before dialysis could be started. That's what I'm thinking.
So maybe a session or two prior to transplant for stabilization, and then. So what are the presumed advantages of a preemptive transplant?
There will not be any complications that we generally see in dialysis patients, like any dialysis related complications like hypotension, hypoglycemia.
So can you vaguely or can you specifically recollect any study or any data which has compared the difference in outcomes between a preemptive and a elective transplant and a non-preemptive transplant?
Maybe we can ask Dr. Bharadwaj if he can help Aman to say any study that compares outcomes of preemptive transplant versus those who have been progressively on increasing duration of dialysis. Dr. Bharadwaj, are you aware of any study?
Your mic is mute, yeah.
No, you're not also.
No, both are quiet. Is it, Aman, is preemptive better than patient on dialysis? Or it is worse than that?
In case of, there might be some amount of the, in case of preemptive transplant, there will be some amount of the native kidney kidney GFR still maintained. So I would think it would be an advantage. But if there is the native kidney disease is still active, then it's a bad idea because there is an increased risk of developing the same disease in the transplant kidney as well.
Anyway, you go back and read that. Preemptive transplant is always better with a survival benefit and graft outcome almost 20% better.
Yeah, I think Meyer Krish presented long term back. This is a study probably a decade old, maybe even older, where there was progressive decline in survival with the duration of dialysis and dialysis. So he had patients up to 6 months of dialysis, 6 to 1 year, 1 year to 2 years, more than 2 years, and then longer duration of dialysis. The longer the person was on dialysis prior to transplantation, these patients progressively had poorer outcomes than those patients who were on preemptive. The best outcomes were in the preemptive transplantation. The graft as well as patient survival.
So the most interesting aspect was that even a dialysis of 6 months had an inferior outcome as compared to preemptive.
That's right.
So
that's right.
That was normally we all would tend to believe maybe 3 months of dialysis is no big deal and you can get a transplant after 3 months. But that study clearly showed even 6 months on dialysis had poor graft and patient outcomes as compared to preemptive. So in this young lady who had a live-related donor or an authorized donor available, so preemptive was a smart idea. So being IgA nephropathy, there would have always been a concern of a recurrence of the disease in the graft.
And Dr. Aman, preemptive usually when the GFR is below 20. Normally people do at around 15. It's not close to dialysis. Suppose the create is something like 9, 10 and GFR is 7. It's not exactly a preemptive one.
Aman, you can also mention now what is the rate of recurrence of IgA nephropathy like this patient had.
Sir, in a study done in the CGSN, they have mentioned that the 10 years recurrence of IgA nephropathy is around 19% and 15 years recurrence is around 23%. And in other studies, they have mentioned the IgA recurrence is around 30% after 10 years in the graft.
Yeah. See, if you do biopsies in people who had IgA nephropathy post-transplant, you might find IgA deposits very often.
Very often.
That doesn't necessarily mean that there may be IgA nephropathy in many of these patients. So just finding IgA deposits on immunofluorescence may not necessarily mean, because you find there are many patients you biopsy, and even in patients where we haven't known the native kidney disease, you find IgA deposits in them. The disease is something else also. The pathology is something else, but they have IgA deposits in them. It's possible that they had probably IgA, we didn't, because the native kidney biopsy was not available. So IgA deposits may be present in many patients post-transplant, but that doesn't necessarily mean that IgA is causing that disease. One has to look at the pathology more carefully to see whether this is related to IgA deposits or is it unrelated to IgA deposits. Just showing IgA deposits doesn't mean IgA nephropathy.
I think that's clear, Aman. So roughly, you should say 30% of patients develop recurrence.
It is common to recur in IgA, but it doesn't cause nephropathy around 30 years.
So rough rule would be 30%. 30% would recur, and of these 30%, approximately 30% would lose a graft because of IgA. So
now, what are you expecting in the biopsy?
Go ahead. Yeah. What do you expect? Anyway, he knows the biopsy report, so there's no point in asking him what does he expect.
And Bharadwaj, I think Dr. Bharadwaj can mention.
Yeah, that would
what
be.
What is he expecting in biopsy?
I'm sure he's also gone through the case.
No, sir. I would expect a recurrence of the disease, sir, with mesangial extension. And in immunofluorescence, there can be deposition of IgA.
What about the vascular changes?
Because of hypertension, they can have arterial.
So we had this discussion, recent onset severe hypertension. So obviously that would have some stigma on the kidney.
Yes.
All right, go ahead.
General examination, her BMI was 31.2. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. Her BP was 130/80 mm of Hg taken in the right upper limb in supine position. Her pulse rate was 60 per minute regular and all peripheral pulses fed. CVS, there were no murmurs. Apical impulse was located in the fourth intercostal space, half-inch medial to the midclavicular line. Respiratory sounds, there were no added sounds. Per abdomen was soft. There was the heel scar of the renal transplant surgery was present. There was no bruit heard over the transplant kidney, and there was no tenderness. And CNS, there were no focal neurological deficits. And the lab reports, her lab reports at admission showed a hemoglobin of 10.5 mg per dl. Her total counts were 6,000. Her platelets were around 2 lakhs. Her creatinine was 2.8. Urea was 60, sodium was 137, potassium was 4, tacrolimus levels were around 2.89, a little on the lower side. The RBCs were 2 to 3, protein was 2 plus, casts were nil, and a unit spot protein creatinine ratio was 1.2 at present admission.
Okay. So what do you think would be the outstanding findings in this for ruling out your differential or keeping in your differential diagnosis? So now you have a differential diagnosis on history and you have a set of investigations and the examination findings. So what investigations here you would suggest either support one particular differential or rules out the other differential?
Sir, I will be able to rule out TMA because There is no significant thrombocytopenia, and the anemia is not very significant. And recurrence of IgA also seems unlikely because there are not many RBCs in the CUV. Proteinuria is 2+, and tacrolimus levels are lower, little on the borderline, so they're a little lower.
So, why do you think the frothing happens in urine? What is the usual proteinuria level at which the frothing would happen? So, the urine spot protein creatinine is 1.2, right?
Yes.
But
Yes.
she definitely presented with a history of frothuria, right?
Yes.
So, what does frothuria indicate? What is the importance of taking that in history?
Frothing of urine would indicate that the patient is losing protein in her urine cell. It is indicative of a it could be indicative of a glomerular pathology. Sir. A glomerular, there's a glomerular involvement, specifically.
And why does frothing happen? Why does frothing happen in the urine? Because of proteinuria. How does that lead on to frothuria? Is there a physical explanation for that, or what would be the scientific reason for that? Dr. Bharadwaj, if you can answer that. What happens when you put a detergent in a bucket?
Miscell formation and less surface tension, I think. Sir.
Perfect. So the proteinuria actually reduces the surface tension, and that leads on to entrapment of air bubbles, and that leads on to frothiness. But usually that would occur with heavy levels of proteinuria. So you would have patients with nephrotic syndrome presenting with frothuria and not patients usually with nephritic syndrome. So from that history, you would tend to believe that proteinuria would be of a more severe kind. So what other investigations do you think would be important which are not mentioned here?
Can you repeat your question again, sir, once?
What other investigations which are not mentioned here you would like to have before going ahead with the biopsy?
I would like to have DSA, donor specific antibody. I would like to have a coagulation profile also, sir, before I go for a biopsy.
Okay, that is as an indication for a biopsy, requirement for biopsy. Anything else for helping you in your differential diagnosis? And DSA is one. So chronic active ABMR could be one differential. That was there. So you would require DSS. Very good. Anything else?
I would like to, as I want to keep TMA as one of my diagnoses. I would want even the LDH levels.
So peripheral smear, LDH levels, good.
LDH levels.
Anything else? We don't have a serum albumin here.
Yeah, serum albumin also.
So recurrence of IgA, nephrotic syndrome, you would have to see the serum albumins, the lipids.
Yes, sir.
Okay. Carry on.
Treatment history, sir. She was receiving tacrolimus 1.5 mg and 1 mg, but after the TAC levels came, we increased it to 1.5 mg 2 times a day. She is receiving MMF 360 mg 2 times a day, prednisolone 5 mg once a day, tablet nifedipine 20 mg twice a day, tablet moxinidine 0.3 mg twice a day, tablet carvedilol sustained release 10 mg once a day, and tablet chlorothiazide 6.25 mg once a day. And she denies receiving any treatment for rejections.
Okay.
So this is the train of events in her 19-year follow-up, sir. At 23 years of age, she got diagnosed with chronic IgA nephropathy. At 27 years, she underwent a preemptive transplant. At 32 years, she had an emergency LUCS after pregnancy. At 39 years, she underwent a hysterectomy. At 42 years, she had COVID-19, and at 42 years, 6 months, that is 6 months later after COVID-19, she had accelerated hypertension with a chronic allograft injury. That was her presentation to us in December.
Okay, I think
so, as I said,
okay, so risk factors for obesity, recurrence IgA, chronic rejection ABMR. I think so. We have discussed most of the things here. So, as I said, accelerated hypertension, post-COVID illness. We have had,
EMA
all of us
can-
would have seen patients coming with presenting with TMS. So,
yes,
that could have been one important differential which we have missed here.
yes.
And so the other, we had 2 or 3 moot points in this presentation, a very illustrative and a very important case. So we have preemptive transplant, we have COVID illness, we have pregnancy in a patient with a renal transplant recipient. So suppose she had come to you and instead of an emergency and she would have planned her pregnancy, what would have been the important steps which you would have counseled her prior to pregnancy?
Sir, according to the American Transplant Society, the patient before she gets pregnant, she should have a stable renal function for at least 1 year, with no episodes of rejection in the last 6 months, with a proteinuria less than 500. Her blood pressure and should be under control, and she should not have any diabetes. And before undergoing pregnancy or before conceiving, MMF should be stopped 6 weeks before conceiving, and it should be replaced by azathioprine. And we should tell her to practice barrier conception or other things such as progesterone only pill, progesterone implant, and progesterone IUDs can be given to her during the period when the transition is happening from MMF to azathioprine.
What about lactation?
During lactation, sir, she can continue steroids and tacrolimus, sir, but azathioprine, she should plan her breastfeeding generally 3 hours after taking the azathioprine tablet, because it peaks and it starts reducing after 3 hours. So all the 3 tablets are
very good. So now suppose we all have been expecting a recurrence of IgA nephropathy in this case. Suppose it turns out to be IgA nephropathy. What important changes in the management of this patient you would do? So you showed us the list of medications she has been on. So
yes,
how would you go around managing this patient now? So it turns, okay, you show the next slide. I think so it's the biopsy slide only.
Just one small observation. Can you go back to the last slide?
this one, sir.
The drugs you were giving.
Yes, sir.
Yeah. Chlorthalidone. Is it correct to give chlorthalidone to, what was our GFR?
Her GFR right now is around 27, 28.
Yeah.
Before,
so thiazides are not indicated if the GFR is less than 30. All right, go ahead.
And not at this small dose.
May not anymore, Dr.
Not anymore.
But not at this small dose, sir. Then it has to be given at 25 milligrams.
Yes.
It should
As such, with GFR less than 30, you can't give. No, go ahead.
No. I think Rajiv Agarwal has already shown that this can be given in patients of chronic kidney disease at a stage 4 as well. And but the dose he tried was more than 12.5 and mostly 25 milligrams.
25.
So
that's what I said.
Click trial, which was published in New England Journal of Medicine sometime back, does show that it can be given in stage 3 and stage 4, and is found to be effective as a control additional drug for patients of chronic kidney disease, and it does control blood pressure better as well as slows down the progression. So I think it was considered initially that below stage 3, 30 ml GFR, it was not effective, but Rajiv Agarwal changed that, I think, from his click study.
Sir, and as you very rightly pointed out, sir, the study actually showed that it didn't decline the GFR as was initially expected, and in fact stabilized it.
Yeah.
So, but the dose then would be required would be 25
would be higher. Would be higher.
Yeah, 25 milligrams.
Yeah.
So okay, as I said, we think okay, you come to the biopsy slide and then we can go that what changes you would do in this treatment.
Yeah. We will have to finish in next 5 minutes because we have another
We are
case.
almost done, sir.
Yeah.
So management is.
Yeah.
So 5 gloms, all gloms, 1 glom endoglom.
This section studied showed subcapsular core of renal cortex up to 5 glomeruli. All glomeruli show diffuse moderate basement membrane thickening with focal splitting. A segment of one glomerular shows endocapillary proliferation with lymphocytes and neutrophils. The tubulointerstitial findings are 10% atrophy. The interstitium is widened with patchy plasmacytic infiltrate with few lymphocyte infiltration seen in up to 10% of the interstitium. There is mild tubulitis with occasional tubules showing hyaline cast with denuded cells around. There is no evidence of any viral inclusions. There is tubular atrophy involving 10 to 15% of the cortex. Immunofluorescence shows mesangial IgA deposits. Immunohistochemistry report C4D is negative. So in the diagnosis, they mentioned as post-transplant recurrent IgA nephropathy in view of glomerulitis and transplant glomerulopathy, suggestive of a chronic active antibody-mediated rejection. As there were only 5 glomeruli and no large arteries, they couldn't apply the BAM score. So they asked for a DSA to correlate with the proliferative findings. And the mesangial proliferative pattern could be contributed by both. Yes, sir. I have the pictures also. Should I show the pictures, sir?
Okay.
Yes, sir.
So no mention about the vessels. Small vessels would have been there.
No, sir. There were.
So whenever we report a biopsy, we have to have all the 3 components. The vessel, the glomerulus, and the tubular interstitium. So there is no mention about the vessels. They only say large vessels are not there, but the small would be there. Okay, you can show the slides.
Yes, sir. This is the H&E staining showing basement membrane thickening with glomerulitis.
Okay.
And this is a one of the slides which is showing segmental endocapillary proliferation in one of the glomerulus. This is the silver staining showing double contour of the glomerulus, very commonly seen in transplant glomerulopathy. And this is the slide showing tubular atrophy with inflammation, sir. As you can see, there's atrophy here and there's little inflammation in the slide. And this is a slide to show PS staining showing peritubular capillaritis, the 2 or 3 lymphocytes in the capillaries. And CD4 negative and IF was showing mesangial IgA depositions.
Perfect.
Strong, more than 2+.
Perfect. So now, Dr. Ratan, what would be the changes in the management or the current treatment which you would entail?
Sir, as we saw, the tacrolimus level was on the lower borderline, and based on our weight, the MMF dose she's receiving could be a little less than what she requires, sir. So first I would plan to increase the CNI and MMF. Then I would plan to put her on RAS blockade, and I would add a statin, sir.
Okay. So currently what we are missing in this whole profile was a addition of a RAS inhibitor and statins.
Yes, sir.
What about the SGLT2 inhibitors? Would you like to consider them as line of management?
Yes, sir. Yes, sir. Actually, as she is obese, SGLT2 will also help in weight loss. It would also be a very good drug to add. But first, I would add RAS blockade. And after that, if the proteinuria is not reducing, then I would add an SGLT2 also.
Okay. And what would be your target for the blood pressure and the lipids?
Blood pressure less than 130/80, sir.
Okay. Target to achieve in nephropathy?
Yes, sir.
What are the normal blood pressure targets you tend to achieve in your patients with IgA nephropathy? And why do you want to be different in this case?
Sir, we would want a lower blood pressure because she's also having proteinuria, sir. If she was not having proteinuria, then we would target around 140/80. Because she's having proteinuria, we would want to reduce the blood pressure more so that we can reduce the hypertension-induced damage that could lead to proteinuria.
Okay, Dr. Aman. I think so.
Aman,
Any further comments from the
Aman? Yeah, Aman. If you were to, what is missing in the biopsy? If I were to tell you that this is chronic active ABMR, and I don't believe that this is IgA deposits are there, but I don't think it is IgA nephropathy. Now, how would you counter that argument? What is missing in the biopsy that would help you to say whether it is IgA nephropathy or it is chronic active or ABMR or it is both? Now, what is it that you didn't do in the biopsy? An electron microscopy. Whenever you are doing a biopsy in a patient who is where the suspicion is a chronic active or chronic ABMR, I think I would always do an electron microscopy. And I don't know why, as a nephrologist, we should not, especially in a patient where you feel that electron microscopy will help. Now, if you do not find any deposits in the mesenteric area, then IgA nephropathy would be out. But if you find that there is splitting in the basement membrane and that's what is there, then you will know that this is chronic active ABMR and not IgA. So I think an electron microscopy, in my opinion, would be an important, and I would think that it would be still important to look at it. And one should do, obviously, DSAs. I hope you've done the DSAs or not yet.
Sir, we have done the DSA because she left after the biopsy. We have done the DSA. We're waiting for the reports.
Okay.
So that's what we asked. What more would you want actually before going ahead with the biopsy? We all would have done DSAs prior to that. The biopsy does show a split in the basement membrane, so there's no doubt that she has some amount of chronic active ABMR.
Yeah, I agree. But the question is there IgA recurrence or not? It may not be there because there is one glomerulus which shows that there is endocapillary proliferation. Rest of the gloms don't show much of changes. So I am not so sure that this is IgA nephropathy, and electron microscopy would be very useful in this kind of a setting.
Professor Ray, any comment before we go to the next case?
I think it's all fine, well discussed, and whatever
there is a question from audience, logically a common question, that should SGLT2 be exhibited in post-transplant patients? So logically answer is in the first 6 months, we try to avoid it when the immunosuppression is intense and the chances of infection are there. After that, if there is a proteinuria and you are not happy with only telmisartan or ARBs, you can certainly add this, considering an individual case.
But there is not enough study on transplant patients. There are few.
There are few studies available, yeah.
But
so
all of us now have a good personal experience. Actually, we have a good personal experience of using it even in
but if you say in a forum, you have to have a study actually.
There are studies where people have used after 1 year.
Study is a very minimal number.
Yeah.
And even though it is said it doesn't cause a bacterial infection, but we have seen a bacterial infection with SGLT2 inhibitors. So one need to be careful about this, as General Varma has said.
I think well discussed, and we can go to. I think Aman can take precautions next time. There were a lot of spelling mistakes in the slides, which should be amended. Right, we can go to the, any comment from Professor Jha? I think because they have been managing this case. Any other thing which Aman has forgotten?
This case was managed in Apollo Hospital. I am in Kher Hospital. My friend Dr. Somshekhar is in charge of this patient. This was a doctor patient followed well for 14 years. So it gives a good idea how long a kidney can work if it is properly followed. Though immunosuppression was less based on what in the retrospective analysis, both MMF and CNI is looking to be quite low. So that may be the reason for getting ABMR. IgA nephropathy recurrence that sir said the aim should be done to be sure that this is not a kind of deposit only and not a IgA. This will be a good point for us to learn and probably follow it up, etc. I will let you know whether that was positive or not. And I thank you for giving us an opportunity to discuss in this platform, because many things we learn when we're talking with our teachers.
It's a pleasure. I think Professor Kher, just last comment on this. What level you recommend if a patient is 10 years, 8 years, 9 years, after 1 year, I'll say after 1 year post-transplant, what TAC level you should maintain?
Yeah, usually it should be between 4 and 6. That's what is recommended. And there is a study which has suggested that long-term outcomes of kidney transplants are best when the TAC levels are around 5 post 1 year. So usually, but I think between 4 and 6 would be okay.
I think
that would be so. 2.89 was definitely on the lower side.
Less than 3 is what is actually associated with poorer outcomes. So
So possibly that is one of the reasons why this patient was landing amid chronic antibody treatment.
And another thing is interaction between statins and the CNIs. So statins would increase the CNI level and CNIs would increase the toxicity of statins. So whenever you add higher doses of statins in a post-transplant patient, it's prudent to check the CNI levels again and also be cautious of the symptoms which the patient would come back with, especially if he comes back with muscular aches and pains, because the side effect of statins on the muscle toxicity also increases the CNIs. So that's an important interaction which we forget most of the time.
And a patient who becomes pregnant without counseling probably is a very high risk of getting complications. Luckily, this patient didn't have.
So she was fortunate. She was very fortunate, actually.
Yes.
She was really fortunate.
Yeah, this would again, another lesson for this is that every transplant patient, despite being a medical person herself, despite that, she landed into an emergency pregnancy without unplanned pregnancy, then an emergency LSCS, and that kind of thing should be avoided in patients with transplant. So counseling immediately post-transplant about pregnancy, contraception, and all these are extremely important steps which must be discussed by the nephrologist. Nephrologist becomes a primary physician for transplant patients, so they should be discussed very, very repeatedly, and every visit must emphasize about contraception and other things and all that. These are issues which many times we don't discuss with them in the routine day-to-day practice, and this is something important. I think we can go ahead with the next case. Thank you, Aman.
Surprising also.
Presentation. Okay.
Thank you. I think we can go to the next presentation.
Yes,
Thank you, Dr. Aman.
Dr. Aman, you can make it full screen. Yes.
Good evening to one and all. Today I'll be discussing about a case. 57-year-old gentleman, Mr. X, is hailing from Assam. He's a graduate in PA and shopkeeper by profession. He underwent live renal ABO compatible 4/6 HLA mismatched renal transplantation in our hospital in around May 2021. His presenting complaint is a rise in serum creatinine level starting 8 months post-transplantation. This 57-year-old hypertensive male also has a 20 years history of type 2 diabetes, which was apparent, and he was apparently healthy until October 2019, when he started observing easy fatigability, swelling in legs and feet, and decreased urine output. On further evaluation by the physician, he was found to have a raised creatinine of around 4.8. And there is also protein in the urine as told by his physician, and was referred to a nephrologist. He was advised to undergo AV fistula creation and also told the need of dialysis later on by the nephrologist, which he refused at that time. But only in 2020 December, he started having complaints of nausea, vomiting with reduced appetite, for which again he consulted his nephrologist and was found to have a creatinine of 9.2. And at this time, he was started on hemodialysis after a temporary HD catheter, non-renal HD catheter was inserted in his right IGB. Later on, AV fistula was created, which is a radiocephalic fistula was created on his left side, and he was continued on maintenance hemodialysis for 3 times a week. He was receiving regular erythropoietin injection and was vaccinated with hepatitis B and COVID-19. His residual urine output was 100 to 150 ml per day, and he gives no issue of any blood transfusion in the past. Coming to his past history, he's known diabetic since 20 years, which was well controlled with OHS and insulin. He's hypertensive for 8 years, which is again well controlled with antihypertensive. He gives history of diabetic retinopathy, which was treated in year 2019. Coming to personal history, he consumes mixed diet. There's no history of any addictions. He has normal bowel and bladder habits, and in family there are no history related to the renal. Coming to renal transplantation, in May 2021, this patient came to our center for renal transplantation with his wife as a potential voluntary kidney donor. After a thorough workup and all the legal formalities, he got admitted 2 days before transplantation and was started on tacrolimus 0.15 milligram per kg per day and mycophenolate 500 mg thrice daily. We have done a T-cell cross-match which was negative, and he was given ATG and methylprednisolone as induction. He ended this renal transplantation was uneventful, and his urine output was good immediately. He was maintained on tacrolimus 0.15 milligram per kg per day and mycophenolate 500 mg thrice daily, and was also started on oral prednisolone. In the immediate post-transplant, patient was apparently all right till post-op day 6. Only when there was a rise in creatinine, for which a graft biopsy was done on post-op day 7. He was told as having rejection, and he received pulse methylprednisolone injection over a duration of 3 days. Then later he was discharged with a creatinine of 1.81 milligram per deciliter with maintenance immunosuppressants like tacrolimus, mycophenolate, oral prednisolone, which were tapered down over time, and also he was discharged with CMV and PCP prophylaxis. He achieved an adult creatinine of 1.4 in July 2021. But only in February 2022, that is 8 months post-transplantation, there was a rise in serum creatinine to 1.9. His baseline creatinine was 1.4. It has raised to 1.9. And his tacrolimus trough level at that time was 11.4. There was no history of any hematuria or proteurine. There is no significant decrease in urine output. There is no recent increase in any antihypertensive medication. His CBC elective were normal. There was no pus or proteinuria. We have done a USG graft to see for any vascular or urethral causes, but it was normal. He was advised for a graft biopsy, but he refused at that time. So coming to differential diagnosis in my case, first I would keep the tacrolimus trough level was pretty high in this patient. So I would think of a CNI toxicity. Then next DD would be a rejection. Next would be infection. And the last I would keep recurrence of native kidney disease or de novo GM.
Dr. Bharadwaj, based on your
Yes,
presentation, how do you rate this patient as so far his immunological status is concerned? Is it a low risk transplant where you require lesser kind of immunosuppression, or a high risk transplant? Because this is a 60-year-old male live donor, 4/6 match, no blood transfusion. And why
so he's a low risk transplant, sir.
So what is the recommendation from the KDIGO about this induction therapy for transplant? Is it
we do
ATG or basiliximab? And what dose is usually recommended by the kidney group?
So in our institute, we follow, we generally don't give basiliximab, sir. We give most of the times ATG. And in coming to ATG, we give around 3 milligram per kg dose, sir.
Single dose, or is you give it in
No,
divided?
sir, it is divided into 2 doses.
How is the ATG given in the patients? How do you give it? Have you ever seen anybody being given ATG?
Yes,
How is it given?
it is given slowly over 2 hours.
It is a very, very vague answer. Like you mix it in some fluid, you give it in the central line or the peripheral line. How many
Because
hours?
how you start, what is the pre-medication, how many
Yes.
hours you give, you have
So
to
we
tell.
pre-medicate the patient with hydrocortisone, sir. Then we start ATG. It is given slowly. We dilute the ATG and we give it slowly and see to it that 50% of the ATG is given before the anastomosis is done.
Right.
Okay.
Slowly means what? Dr. Bharadwaj, slowly, I am not so sure. Slowly is what?
How much
1
time?
hour, 2
time?
hours, 6
Is
hours,
it-
how much?
Is it dependent on the dose and what do they? So you give 1.5 milligram per kilogram body weight, which is say around, if it's a 70 kg man, would be something like 100 or 100. So how would you give 100 milligrams of ATG over what period of time? In how much of saline would you dilute it?
You've given yourself.
I'm not sure whether you've given it yourself. Have you given it yourself or watched it being given also or not?
Or watched it being given.
You watched it. You haven't done it. So have you been to the OT for
Yes.
transplant?
Yes,
Have
sir.
you seen a transplant
Yes, sir.
being done?
Yes,
You've
sir.
seen it. So then since you use thymoglobulin very often or almost in every patient, then I would want more details from you. In fact, you should be the most experienced person to give us details of how to give it.
Bharadwaj, if half the dose goes up to the anastomosis, then what will be the normal hours? Simple.
After those, if it around 2 hours would be before anastomosis, sir. Then rest will be giving in the transplant unit.
Okay, go ahead.
Okay. In this patient, you have been monitoring the tacrolimus level. Is there anything that you do in addition to tacrolimus level for deciding whether this is a fast metabolizer or slow metabolizer or intermediate metabolizer? Do you have any other kind of assessment that you do at your center?
We don't do, sir, but actually, ideally, we have to do a CYP3A5 analysis.
So genetic testing can be done to look at the homozygosity or heterozygosity of the CF8 to decide whether this patient is having a toxicity because of genotypic abnormality that is there. So in this patient, yes, sir.
No, you can go ahead. You make your comment.
In this patient that you said, that patient was given ATG and still he developed a kind of acute rejection within 7 days. How common is acute rejection with this kind of immunosuppression in a low risk transplant?
The chances of rejection are around 6 to 7%.
So,
Dr. Bharadwaj,
yes,
Dr. Jai had asked you a question. What are the current guidelines? The last guidelines were written in 2009. Unfortunately, they are too old. But what are those guidelines about low risk? You said this is a patient who is low risk transplant.
Yes.
But what are the current guidelines? 2009 guidelines say for low risk transplant, what kind of induction should be given?
For low
You
risk,
may not agree with the guideline, but what is the guideline?
For low risk, they recommend to give basiliximab, sir, as induction agent, which is.
Yeah, they want to give. So why do you think your center and Dr. Ray thinks that he wants to give hemoglobin. So what are the problems with the recommendations? And why would
Okay. I think it's not completely low risk. There is complete HLA mismatch 6/6. We have our study where whenever we have used Simulac, the SCR, the rejection, acute rejection rate has been around 15 to 17%, around 15%. And when we have used thymoglobulin, it comes down to 5 to 6%. That's a significant, and being a large volume, we have our own experience. So we usually use thymoglobulin. And that's in a relatively lower dose. We use 3 milligram in 2 divided doses.
Please go to the next slide. Let's see what are the other things.
Excuse me, what are the infections you are looking at?
It's a BK virus.
So you should specify. Infection is a very vague term. So a patient who has received ATG induction has been pulsed with steroids soon after transplant, has had high attack levels. So very high chances of it being actually BKV.
Yes.
So that in fact should be the first diagnosis. Would not it be? If I have
Yes,
to
sir,
give the differential, I would give BKV as the first differential.
Yes, sir.
Let's go to the next slide.
So in this patient, we have done a plasma BK virus DNA quantitative analysis, and it was found to be, we got around 50,000 copies per ml. Then what was done was the dose of tacrolimus was reduced. Initially, he was taking 3.5 mg twice daily, which was reduced to 2 mg twice daily. Mycophenolate, which we was taking 500 mg thrice daily, was stopped, and he was started on leflunomide 20 milligram per day. Then we asked him to do his BK virus PCR test every month and come for a follow-up. But initially he could not come because he was from Assam. But only in the month of July 2022, he came to us. When his BK viremia persisted, but the copies have come down to 30,700 from 50,000. And even the creatinine has come down to 1.6 from 1.9. But only in August 2022, that is 1 month, 2 months later, 1 month later, his BK virus persisted, and this time the copies have gone up to 84,000, and even the creatinine raised to 2.06. So he was given IVIG around 30 grams in total, which was divided over 3 days. After this, the creatinine kept increasing over next few months, and at this time, he also started noticing mild pedal edema in both the lower limbs. And in December 2022, the creatinine went up to 2.26. At this point, even the patient didn't have any proteinuria, but the PK viremia was only 2,500. We have done a USG graph again to suit for any vascular or else urethral abnormalities, and it was still normal. Tacrolimus stuff level at this time was 5.6. So we have done a graph biopsy. These are the biopsy findings. So the glomeruli showed mesangial matrix expansion. There were no capillary wall thickening or basement membrane splitting. There is no proliferative lesion. No, there was no glomerulitis, piping thrombus, or necrosis. Coming to tubules, there was moderate degree tubulitis with 50% of IFTA, and the interstitium showed diffuse moderate degree infiltration by lymphocytes, plasma cells, and eosinophils. In blood vessels, there was no arteritis or capillaritis. There was no intimal fibrosis. We have done immunohistochemistry. C40 stain was negative in peritubular capillaries, but SV40 stain was positive. IF showed no immunoglobulin deposition. So the impression was polyomavirus nephropathy with chronic active cell-mediated rejection. Keeping in the rejection, we had to increase his oral prednisolone dose to 10 mg from 5 mg. And over next month, the creatinine reduced initially to 1.6 in January, only to increase to 2.12 now in February. So again, we have increased the prednisolone dose further, and he's receiving 20 milligram daily. So if at all you see the creatinine, he underwent transplant. Here, when he was discharged, the creatinine was 1.81. He achieved an adult creatinine of 1.4 in July 2021. And in February 2022, that is 8 months post-transplant, BK was detected. And at that time, the copies were around 50,000. We have reduced the immunosuppressants, and the creatinine came down to around 1.66 in June 2022. But we have given an IVIG in August because the copies and the creatinine, that is the BK viremia, persisted with raising copies, and also the creatinine has raised. So we gave an IVIG in August 2022. And we performed a graft biopsy in December 2022 because here the BK viremia has decreased to 2,500 copies, but the creatinine kept rising, and we were thinking of any rejection. So summarizing my case, this is a 57-year diabetic hypertensive gentleman, known case of ESRT on maintenance hemodialysis, 340, who left radiocephalic fistula for 2 years, underwent Lyme-related ABO-compatible renal transplantation, wife being donor with 4/6 HLA mismatch, had normal immediate graft function, who developed graft dysfunction on 7th post-op day in the form of ACL, which was treated with pulse methylprednisolone, to which patient responded well, only to develop graft dysfunction after a duration of 8 months, which on further investigation was found to be due to polyomavirus nephropathy with chronic ACL.
Dr. Bharadwaj, are you convinced that this patient is having a chronic ACR, or is everything a polyomavirus nephropathy? How do you distinguish it? Because both the things could be coexisting. You have said in your slide that there is no vasculitis, there is no vessels are not involved. There is no infarctitis, nothing is there, which is usually a part of ACR. And rest of the things could be seen in both the situations.
Sir, we were thinking of chronic ACR only because the creatinine is rising despite the viremia which has come down.
According to BAM's classification, how is the TCMR is classified? Like, is it acute, chronic, acute and chronic? How do you classify that, first of all?
Sir, there is borderline TCMR, there is acute, and there is chronic. In acute T-cell mediated rejection, there is tubulitis, but there is no intimal fibrosis or artery involvement. But in chronic T-cell mediated rejection, there is intimal hyalinosis along with tubulitis.
But correct, etc.
Dr. Bharadwaj, with mild tubulitis, can it be only BK virus?
Yes, sir. With mild tubulitis, it can be only BK virus nephropathy.
Mild tubulitis you can get in BK also, no?
Yes, sir.
Unless it's difficult at times to differentiate, unless it is quite large tubulitis or bigger tubulitis, normally you will think it is associated with BK, with these kind of findings.
Dr. Bharadwaj, have you heard anything about the half-life of kidney in transplant? Like, this patient is a live transplant. What is the expected half-life based on the recent immunosuppression in the literature? What is the half-life of the transplant? You know, or you do not know?
No.
Okay.
What is the half-life?
You know about half-life of drugs? Dr. Bharadwaj, you know about half-life of drugs? We say talk of the half-life of a drug.
Yes. Yes, sir.
Yeah. So what is that? Can you explain it in pharmacological definition of a drug half-life? Then you might
is-
be able to sort of. So what does it mean? What does half-life mean?
the half-life of the kidney means uh,
Okay.
duration
Aman,
of
are you there? Aman, are you there?
I don't know. Yes.
Aman is
Yes.
logged off, or Aman
No,
is
he's
still there?
Sir, I'm here, sir.
Aman, what is half-life?
Half-life of a drug is the amount of time taken to reach half of its concentration.
Half of its concept. And what about half-life of a graft?
Same thing.
Okay. They have to read it. I think.
So
what is the half-life of
why
a-
don't you
Sorry.
tell Dr. Jha what is half-life? Tell them.
Yes, half-life of a transplant means that, like for example, this patient, a live transplant, the expected half-life is around, dependent reports are 10 to 13 years. That is 50% of patient will become dialysis dependent, but remaining 50% will continue to be off dialysis. They will continue to maintain the graft. As the HLA match increases, the half-life increases. Like for identical transplant.
Yeah.
Yes, sir.
Half-life will become something like, it's the number of people. If 100 people are transplanted, how 50 of them will do well for how many years?
Yes.
So half-life is that life.
In a live donor transplant, the half-life is normally around 14.
Yes.
If we go for a depth-censored one, it will be around 17 to 18 years.
For actually identical transplant, 20 to 25 years is the half-life.
That will be higher. That will be higher.
Yes.
May I?
At times,
25 to 30
we
years. So
actually make
that's
it. At times we make it the amount of functioning grafts after 1 year. So this is basically to exclude those early graft losses. So the amount of grafts which would be functioning after n number, 50% would be functioning after n number of years of those who have been functioning after 1 year.
at the end.
So जैसे infant mortality rate or neonatal mortality rate निकालते हैं, so we exclude those earlier losses. So after 1 year, of how many would be surviving?
Yes.
But to both Aman and Bharadwaj, what percentage of graft is usually lost in 1 year in a live donor situation?
Aman, what's the 1 year survival of transplants? How many grafts would be lost?
Live transplantation is around 95 to 96%, sir. In deceased donor, it is around 87%.
1 year survival should be about more than 90%.
Around 97 in a live donor.
Yeah. It should be about more than 95% in live donor transplants. Any good center should be 97, 98% or so, by and large. But yes, 95%, and cadaver maybe something like 90 to 93 or so these days. But yeah, it could be lower in disease donor transplant. That's good. Yes. No, Dr. Ray, when I got disconnected at that point of time, the point I wanted to make about the induction therapy was basically that Dr. Bharadwaj should know why is it that over the last decade or so, the transplant guidelines are 2009, and most of that guidelines were based on cyclosporin era.
Yes.
Tacrolimus was not included in those guidelines by and large, because tacrolimus was not used in many of those studies where the guidelines were laid down. Over with tacrolimus, the impact of interleukin-2 has definitely gone down, and therefore more and more centers have started using thymoglobulin. And there is good amount of data on which for those guidelines. I'm sure the guidelines are going to be rewritten on the recipients, and then one will look at that the induction therapy will become thymoglobulin. I agree with you.
Dr. Bharadwaj, this patient has a BK virus nephropathy. What are the diagnostic criteria to make a diagnosis of BK virus nephropathy? Do you go by urine report, blood report, or biopsy? All things have to be combined.
So for BK virus nephropathy, it can be a presumed BK virus nephropathy or it can be a biopsy-proven BK virus nephropathy. If the BK viremia, that is the plasma PCR count, is more than 10,000, then we presume it as a BK virus nephropathy. And it can only be confirmed by a renal biopsy, where we have to see for any inclusion bodies or else SV40 stain, positive SV40 stain in immunohistochemistry.
So, in this patient, based on the follow-up, what do you think that he requires to have a lower loading of the immunosuppression, or you may have to hike it up, etc.? You said that the rejection, you thought about it and you give the increase the dose of prednisone based on the follow-up, because many things may not be, one cannot be sure about it, etc.
Yes. In this patient, actually, what we plan to do now, sir, is a repeat biopsy testing, because the BK viremia's count has come down. So we are even expecting the BK virus nephropathy to come down. And if at all in a real biopsy there is only rejection, then we will act accordingly.
Bharadwaj, just one or two things. First, you should know ATG is given over 6 to 8 hours. It is not given over 2 hours, what you were mentioning. All right. That is different. Some people try to give it before the patient goes to OT. So you give it in 0.9% saline to go over 6 to 8 hours. The question about the present case is, what do you think? Because in the biopsy, you have seen IFTA of 50% already. Do you think there is anything salvageable in this patient? And why do you think, is this a normal course of BK virus nephropathy that you have given? You have reduced the immunosuppression. The count did start come down. Why did the count go up again? You brought it from 50,000 to 30,000. Again, it went to 84,000. What was the reason? There must be something. Was the immunosuppression unchecked? Did the patient take more drugs? What was it? Because he has remained with good viremia over a lot of 3 or 4 months. Yes. With the result, whatever the BK virus nephropathy was there, it is going into state of fibrosis. The IFTA has already set in 50%. At this point of time, that is what you say, to almost 25% of the kidneys, they get lost if a person develops BK virus nephropathy. So this is a classical thing that I really don't know how much salvageability will be there in this patient. Professor Ray, I think Professor Ray can.
One is about ATG. It's around 6 to 8 hours, and I expected Bharadwaj, because he has done around 4 months transplant duty, must have seen this. I was expecting all my residents to know this. The problem is with the BK, it may not respond to a lowering of the dose always. Yes. That's why normally people will stop or lower the anti-proliferatives, mycophenolates, and then if it doesn't work, they will lower the CNI. And if it doesn't work, probably one can add on some drugs, even though it is well known these drugs may not work. So it may be at times very difficult. This patient has more or less persistent BK viremia for a longer period. So it must be a bad kind of BK viremia. I don't agree there has been a SCR with the biopsy report. I believe it is all BK virus problem. And maybe, as you said, when was the biopsy done?
December 20. Last year, December.
Last December, 2-3 months. Maybe the IFTA has gone up. That's why chronic changes has gone up. That's why creatinine is up. But you are right in doing a biopsy because you have significantly reduced the drug. So there is always a chance of SCR. SCR can be with the BK virus. SCR can be because of the suppression of or decreasing the immunosuppression. So by doing a biopsy will give us an idea if by chance there is a SCR and the create is off, but the counts are low. One may again give little more immunosuppression, may not give a pulse, may increase the CNI and mycophenolate doses.
Professor Kher, sir.
Yeah, no, I would agree with it. I think the diagnosis of BK virus in this patient, in my opinion, was late. I think he has had chronic BK viremia for long periods of time.
Yeah.
And I think the immunosuppression, in my opinion, was reduced half-baked. I would have stopped MMF totally. I would have reduced mycophenolate. I would reduce steroids as well. I agree the fear of acute rejection doesn't allow nephrologists to reduce immunosuppression in patients with BK virus nephropathy. If I can tell you from my experience, majority of patients where I have been able to reduce the immunosuppression, they recover. And the viremia went down in this patient, it went up again. I think the immunosuppression needed to be reduced further, and I'm sure he would have recovered from BK virus viremia much earlier than what has happened in this patient. So personally, I feel we should have been more aggressive with this, and I feel it's been now chronic changes.
Yeah.
I don't think there will be any reversibility as far as IFTA and other things are already set in. And I think the rise in the creatinine is now probably related to chronic allograft, IFTA, and all that, rather than any aggravation of BK virus or an acute rejection, probably.
Yeah, I agree. Professor Kher, I agree with you. Normally, I stop mycophenolate completely, and majority of cases are almost all cases the BK virus number goes down. The viremia goes down. It is absolutely true. If the creatinine has been around say 1.6, 1.7, it may not come down, but it doesn't go up. It maintains in that. That's my personal.
That's right. That's very true. Very true.
Yeah.
So I would think that that's what would happen. See, BK virus and cytomegalovirus infections it should be a message to a nephrologist that please reduce my immunosuppression. These are viruses which get aggravated only because of high immunosuppression. Net immunosuppression is high, the net immunosuppression has to come down and significantly come down. So be proactive for reduction of immunosuppression. Watch them more carefully. There's no doubt about they need to be monitored closely and very, very regularly till they recover from BK virus viremia. And then I think as the viremia gets better, the BK virus also gets, and the kidney function, if it doesn't recover, but it will stabilize. I would agree with Dr. Ray that it would stabilize. And there are many patients who will have this creatinine going on for many years of life after having been recovered from BK virus.
Sir, I completely agree. It's very important actually to reduce aggressively, follow up the BKV levels every 2 weeks or 4 weeks, whatever is possible, and keep on reducing till you disappear. Another important point which we often forget is reintroduction of the immunosuppressant. So once you are clear of BKV for a period of time, then maybe it's also wise to add some immunosuppression back. So, but it's not before we lead on to complete clearness of BKV viremia, not before that.
Also keep in mind that many times the biopsies in these patients show a lot of plasma cells. So at one point of time, there used to be entities like plasma cell rich rejection. And I remember during those days, BK virus was not there in 2000 or 2001. So that is the time we used to give more steroids. The patient has got rich plasma cell rejection, we give steroids because we were ignorant that time. And
it was labeled as steroid non-responsive rejection.
Yeah. And later on today, if you suspect in a biopsy the plasma cells are there, you should become suspicious that I have to do BK viremia. I should study about the BK virus. I personally feel these two cases, Dr. Mahajan, any further comment from your side?
No, sir, perfect. So both cases have been very illustrative, telling us two different aspects of chronic graft loss.
Yeah.
So One was a disease occurrence, and the other one was BK virus leading on to chronic allograft nephropathy. So very
I think very bold case. Thank you very much, Professor D.S. Ray, for giving the case. I mean, that is a lesson to all the students also, that what fallacies occur and how aggressive we should reduce the immunosuppression. That's a message to nephrologists. And I'm glad that almost 90 plus nephrologists are online listening to the presentation, including Zoom and this. Professor Kher, sir, for your final comment. I personally feel all the examiner and expert have done really great job, and the cases have been very well discussed. Professor Kher, sir, for final comments.
Yeah, no, I think only one thing which I would request the students that they are working, like Dr. Bharadwaj is working in a very high output transplant center, and he should have been more knowledgeable about the practical use of these. And it would suggest that probably they don't do it personally. They theoretically they want to read it from books, but that doesn't tell you how to give it. The details will have to be seen how to be. So I would suggest that every DNB or DM resident must go and see transplants being done and look at how these drugs are administered and look for complications in these patients. So probably being in the ward and on the floors rather than reading books only may give you much more information of practical value, as well as help you to learn what you see on the floor. That's what my suggestion would be. I think very well discussed cases, very well illustrated. I would like to thank you on your behalf, both the examiners, Dr. D.S. Ray, and the students, both Dr. Bharadwaj and Aman, for being there and presenting these cases. And I think I would request the sort of thank the audience as well for being in good numbers to be listening to all this. It's been very, very educative, I can tell you, on my personal behalf. And I, on behalf of you as well as my own self, would like to thank Mr. Raja as well as his team from Microlabs, and would like to thank everybody else. Wish you all the best. Good night. Thank you very much. And see you in another 2 weeks for the last session, this session.
Last session.
And then we will come back.
There's a small question that we will not leave some audience has asked about leflunomide. I think it was given in this patient. And
Yes, sir.
Professor Ray, any comment about
even
status?
though there is no definite proof, but we do give, and I think it works. This is personal one. But if you go by the literature, I don't think there is very definite.
We don't have a definite data, but possibly.
If you ask me, I don't use it.
It
doesn't work.
Don't use it, but the question is from the audience that the status of that may not be great, but individual cases.
And it has mild immunosuppressive action also.
Okay.
Yeah, that's right. I think it adds immunosuppression. You are not reducing immunosuppression by giving leflunomide.
Yeah, it's
So
an
I would
immunosuppressant,
think
sir.
that.
Not to
So
forget, it's an immunosuppressant.
Yeah, so I would not give it. Personally, if you ask me.
Well, we stop here. Thank you very much.
Thank you.
Okay.
Bye-bye.
Bye. Bye, sir.
Bye-bye.
Bye.
And thank you, General.
Thank you, sir.
Pleasure.
Thank you, Varma, sir.
Pleasure.
Thank you, sir.
Thank you, Aman.
And thank you especially for Dr. Ratan.
Thank you.
Thank you very much for your valuable time, and all the panel speakers and chairpersons and attendees, doctors. Thank you, doctor, on behalf of Micro.
Thank you.